I present the next speaker is Enrique Moratalla. Enrique, come here, please. And she's from Spain. She's the head of the laparoscopy and hysteroscopy unit at the Hospital Ramón y Cajal and at the Hospital Monte Príncipe. And he's going to talk about endometrial ablation with a new NovaSure V5.
Okay. Thank you very much. I would like to thank Hologic for this invitation to participate in this symposium. I'm going to talk about endometrial ablation with NovaSure V5. NovaSure is a second-generation endometrial ablation device that was launched in 2002. During those 20 years since the commercialization, it has gone through several evolutions. In 2008, the RFC09 device was launched, and in 2016, the NovaSure Advanced device appeared. Now, the NovaSure V5, a new device that improves the previous ones, has just been marketed. Throughout these 20 years, more than 3 million patients have undergone endometrial ablation with NovaSure, demonstrating the safety of the procedure. NovaSure V5 incorporates accuracy markings, which allows to confirm that we are inserting the device under lens previously obtained with the hysterometry. It also incorporates endoform in the cervical collar. The new system will allow us to perform better cervical occlusion, favorite vacuum and uterine cavity integrity assessment system, and it also helps to reduce intervention times by improving the contact of the cavity with the mesh thanks to this better vacuum. In this slide, we can see the previous device, NovaSure Advanced, with no marks indicating the length of the device introduced into the uterus, and how the cervical collar was the same width throughout its length. In the latest cervix, multipolar woman, this could mean that the vacuum could not be performed properly, and the procedure will be stopped as a safety measure. Below, we will see an endometrial ablation performed with NovaSure V5 in our hospital, Ramón y Cajal. We began by performing an hysteroscopy, passing through the endocervical canal and visualizing the cavity. It is a regular cavity with a proliferative first phase endometrium. We always perform a biopsy prior to the endometrial ablation. In this patient, the anatomopathological result was proliferative endometrium. We then proceed to perform the hysterometry. In this individual patient, the uterus was 8 centimeters long. Subsequently, we perform a cervicometry, introducing a Hegar dilator up to the internal os to obtain a measurement of 3 centimeters. Subsequently, therefore, the cavity will have a length of 5 centimeters. That is the result of subtracting the result of the cervicometry from that of the hysterometry. This is the measurement when we introduce as the length in the device. We check the dispensable device, how it unfolds properly, and how the wheel that indicates the width moves when we squeeze it. Make sure the array is completely enclosed by the external sheath. After dilating the cervix with a 6 mm rod, in some cases a 7 mm rod may be needed, we proceed to connect the filter and the device. We introduce the measurement of the length of the uterus in the device, in this case 5 centimeters. Advance to the fundus in line with the axis of uterus holding the blue front handle. Withdraw the dispensable device approximately 0.5 centimeters from fundus. Place the device by using the accuracy markings to confirm depths of fundament placement. When inside, we open the device and pull it slightly. Then, we rotate it 45 degrees both ways in order to expand the NovaSure membrane and get the appropriate width measurement. In this case, is 3.4 centimeters. Hold tenaculum, advance to the fundus, and slide cervical collar. After imputing the data, we press the foot pedal and the endometrial ablation begins. In this specific case, the procedure lasted for 1 minute and 7 seconds. Subsequently, we remove the NovaSure device and we perform a hysteroscopy to confirm the successful endometrial ablation. During the procedure, we observed that the previously present endometrium is completely necrotic due to the radiofrequency endometrial ablation.
Our next speaker is Dr. Covadonga Álvarez. He is the head of hysteroscopy unit at the University Hospital of La Paz, professor of the Department of Obstetrics and Gynecology at the Universidad Autónoma de Madrid. And she's talking about myomas and MyoSure ensuring a high degree of success.
You will learn a lot.
So, thank you very much for the invitation. I will show you two clinical cases solved with MyoSure, so two difficult clinical cases. The first of one is a woman, 39 years old, female patient with a submucous fibroid from the infertility clinic, BMI more than 20, on the sogestrel treatment for 2 months, normal examination, ultrasound, so as a hysterometry 12 by 7 by 5, endometrial line 2 millimeters. Has 6 submucous myomas, G1, G2, size between 4 and 1, all of them with a peripheral vascularization Doppler score 2 or 1. So we are going to face a high complexity myomectomy, and we are going to face it in office. As you can see, our first myoma is a myoma type 01, 4-5 centimeters. And our goal is going to be separate the myoma from the uterine walls, because we know that if we separate the myoma from the uterine walls, we could finish this myomectomy. All of us, Jaimovi saw us in her amazing multi-center study, that we could leave the myoma inside the uterus and the patient are not having any problem, any pain. In this case, the consistency of the myoma is soft, so the tissue removal of the device are going to be high. That's why this myomectomy are going to take short time. In a few minutes, we could finish our first myomectomy. If we have only this myoma, we could finish, but we have a second myoma. Move on the second myoma. It is a type 2 myoma. We are going to perform the same technique, separate the myoma from the uterine walls, so we are finished our second myomectomy. Now move on to on the third myoma. It is a myoma size 3 centimeters, type 2, and in this case, the consistency of the myoma is a little bit more hard, so our tissue removal of the device are going to be a little bit more low. the surgery are going to be a little bit more long. In this myoma, we need to change our movement, depends on the discomfort of the patient. You need to remember that we are in an office without anesthesia, with IV line. This is the fourth myoma. Again, it's a myoma with a soft consistency, so we are going to remove it very quick, as you can see. Okay. We don't need to remove the free pieces of the myoma, but in this case, we are going to perform that because this disturbs our visualization to our next myomectomies. Well, the intramural portion of the second myoma are fall to the cavity, so are going to finish this part of the myomectomy. Now we are going to remove the free piece. We know that it's not necessary, but it's better to have better visualization. Now we are going to perform our fifth myomectomy. In this case, we have a small myoma but with a hard consistency. So in this case, the tissue removal of the device are going to be low. We are going to need more time to remove it. Okay. And the next one, we have another one. It's in the right lateral wall. It's a myoma with a high intramural portion, as you can see. So we will perform an intracapsular myomectomy. We could reach well with the device. And we are going to finish this sixth myomectomy. So we perform this surgery in office in 70 minutes. The second case is a 41 years old infertile patient referred for hysteroscopy for submucous myoma and heavy menstrual bleeding, undergoing IVF treatment for 2 years, awaiting transfer of 2 frozen embryos, BMI more than 30, on desogestrel treatment for a month, normal examination, and the ultrasound shows a hysterometry 10 by 8 by 5, endometrial line 2 millimeters, submucous myoma more than 50% intramural, site 4 centimeters in posterior wall, peripheral vascularization Doppler, score 2, normal ovarians. Again, we are going to face in office a high complexity hysteroscopy myomectomy. As you can see, we are going to face a myoma with a high intramural portion. So we will perform an intracapsular myomectomy. We need to find the cleavage plane and cut in this cleavage plane around the myoma, performing a similar technique like opium. So we are cutting around the myoma, always in the cleavage plane, trying to find the right space between the myoma and the pseudocapsule. Okay, just in this moment, we find this right space. We are between the myoma and the pseudocapsule, so we need to cut the bridge, the collagen fibers that are joining the myoma with the pseudocapsule. And by this way, the intramural portion of the myoma are going to fall into the cavity, and we could remove the myoma. We could separate the myoma from the pseudocapsule. We only need to put in touch the shape with the myoma because we don't want to damage the pseudocapsule, because we know that the pseudocapsule are going to heal the myometrium. Sometimes we can't reach the fundus of the pseudocapsule, so in these cases we need to remove the myoma to have more space to reach this part of the pseudocapsule. The fundus always is the worst part, the more difficult part, because sometimes the device don't reach well. So we are finishing the myomectomy. One moment. So this is the pseudocapsule without any damage. And as you can see now, this myoma had a high intramural portion, and we performed this surgery in 8 minutes in office.
And the last speaker is David van der Ham, and he's gynecologist at Martini Hospital Groningen in Netherlands. And he's talking about hysteroscopy removal of retained product of conception using NovaSure and Omni 30 degrees and fluent and advanced fluid management system. Okay, the floor is yours.
Thank you very much, and it's again an honor that Hologic invited me to talk about the improvements of intrauterine RPOCs and the removal of them using NovaSure and the Fluid Advanced System. And as said, I'm David van der Ham, gynecologist in the Martini Hospital in the Netherlands. Before continuing talking about RPOCs, I would like to show you the changes we made in the last years, moving hysteroscopy from general procedures under anesthesia in the OR to more procedures done in the office setting. Before 2015, in our hospital, hysteroscopy was still considered as the little sister of the endoscopic surgery and was seen easy to perform. We did diagnostic hysteroscopy in an ambulatory setting, but sometimes due to logistic reasons, we also did it in the OR under general anesthesia. And the therapeutic hysteroscopy were mainly done with a 9mm resectoscope when they are large, and only the small one were done in an office setting. And all gynecologists performed these procedures. So from 2015 on, we made some changes which dramatically changes the way where we treated the hysteroscopy. As you can see here, at the beginning of 2015. We introduced procedural sedation and the NovaSure as a morcellator. Procedural sedation is a level 3B pain medication using IV pain and sleep medication. And this already gave a dramatic decrease of the procedures we could do in the under general anesthesia and in the outpatient setting. After the first sharp decline, it stabilized a little bit because we had to find out what could be done on the procedural sedation and what could be done in the office setting. And then we decided that not all gynecologists should do hysteroscopy, but there are only a few of our staff members doing the hysteroscopy, and we introduced the omniscope. And this again made a change in where we did the office hysteroscopy. In the spring 2021, Hologic asked our hospital to be part of one of the 10 LMR sites to introduce the new fluid management system, Fluent. We also introduced the 30-degree omniscope. And both instruments gave us the possibility to even change the way where we did the operations further. And this is where we stand today. In the end of 2022, we performed only 3% of all procedures in the OR, and they are mainly due to logistic reasons. But more interestingly and more promising, more than half of our procedures were now done in the office setting without any anesthesia or only pericervical anesthesia. During the transition from the OR to a more ambulatory setting, we also changed our approach of how we remove the retained products of conception. As we know, retained products of conception is a common complication of pregnancy. 1% of all full-term pregnancies are complicated with the retained product of conception, and up to 15% of all miscarriaging. Patients will show to you with signs and symptoms of abnormal bleeding, abdominal pain, and persisting dilated cervixes. And if not treated well, you will end up with endometritis or intrauterine adhesions. The diagnosis of an RPOC is mainly made by an ultrasound, but sometimes may be very difficult to do. As an RPOC is a common complication in pregnancy, how should we treat patients in a safe manner? These are two screenshots from two big guidelines. And as you can see, both guidelines do still recommend a vacuum aspiration or a curettage, and none of them advises to do an hysteroscopy. And they're not from the smallest parties, they are from the ACOG and the NICE guidelines. So this I found a little bit disappointing because we all know DNC is a blind procedure and is associated with up to 30% of intrauterine adhesions. And in 1997, so 25 years ago, the first time it was, the first hysteroscopic removal was reported by Goldberg. So if we list the benefits of hysteroscopic approaches, in my opinion, we should consider a hysteroscopic approach for all patients with an RPOC unless they are very heavy bleeding or hemodynamic unstable, because it's not a blind procedure and reduces the risk of perforation. You have direct visualization, so you don't have to injure healthy tissue and you can completely remove the tissue. Furthermore, you can identify uterine anomalies in case of patients having recurrent pregnancy losses, reduces the abnormal embryonic implantations and also the risk of intrauterine infections. After the first publication with the cold loop resector, other manners of removing RPOCs have been reported, and Hammerlich was the first in 2013 to report a removal of an RPOC with a morcellator. Whatever manner you use, the goal from all of us is to empty the cavity with minimal damage. And therefore, not only doing a hysteroscopy, it's also the vaginoscopically approach which minimizes the damage. As we know, the cervical canal is about 5 millimeters wide and nearly always possible to pass without any anesthesia and dilatation. When it's above 7 millimeters, it often requires anesthesia and sometimes requires dilatation, and then still the hysteroscopic approach will be a semi-blind procedure. Furthermore, I think an angle tip of a vaginoscopic approach by using, for example, a 30-degree scope will make it easier, which I will show you in a slide hereafter. Those people who are not very familiar with the omniscope from Hologic, this is what you get in the box. You have a 3.7 millimeter diagnostic scope, and you have shafts from a 5.5 or a 6.0 millimeter for therapeutic issues. It's very easy to switch from a diagnostic to a therapeutic scope without changing the whole system. And the omniscope is available in a 0 and a 30-degree version, and I myself prefer the 30-degree version, as I will show you. Now a short animation why I think a 30-degree or any degrees hysteroscope will make it easier for you in an office setting to go into the vagina. And especially here, you just use the scope guiding you through the vagina, and also when you have the working channel, it's an oval channel, so you can also twist it a little bit to get the right direction. If you work with the 30-degree scopes and you are familiar to do it with the 0 degrees, it might be a little bit challenging. So this video shows you what the tricks you can use when you're using a 30-degree scope. And one of the most important things is that you have to make sure where your pathology is situated. Because when you're introducing the 30-degree scopes in a normal position, you always look at the anterior wall of the cavity. And as the working channel is above the rod lens, you always have the optic on the front side, which you see also on this video, always looking towards it. And especially in the 30-degree, it will block a lot of your vision if you position it not right. So if, in this example, your pathology is on the side one, you have to move you have to change the position of your scope. So your working channel is near to your pathology and it's easier to remove. And also, when it's not so big pathology like last video, you can also use a MyoSure instrument as a kind of a cold loop just by pushing the tissue loose from the healthy tissue. At the moment I was asked to talk to you about RPOCs, I was wondering what we did in our large non-teaching hospital in the Netherlands, just to see what's common practice. Yeah, I'm speeding up. As you can see here, although hysteroscopy is our first line of treatment, about half of our patients were referred with heavily bleeding, pain, and they need to have an operation within a couple of hours or days. And then we did a hysteroscopy, we did a DNC. But when we could schedule the patients, the majority were scheduled to do a hysteroscopy. And it didn't matter whether it was an RPOC due to postpartum, as a postpartum problem, or after early pregnancy loss. The interval, which is normal, was shorter to do a DNC than to do a hysteroscopy. For the hysteroscopy, on average, we could wait about 64 days. And these are the devices we used. And as you can see, we used more than half the patients, we used a manual or we didn't use anything. In 11 patients, we thought on the ultrasound that there was an RPOC, but in the end, there wasn't one. So this is also something which stresses that you should do a hysteroscopy if you could.